Welcome to the webinar of the Geriatric ED Collaborative. My name is Don Mulady. I'm an emergency physician at Mount Sinai Hospital in Toronto and a member of the Geriatric ED Collaborative. And we're delighted to have you here as I host this session today. We were pleased that this webinar seems to have attracted an even wider, larger number of registrants than many of our webinars do on the topic of delirium. So clearly this is a topic that resonates with anybody working in an emergency department who's focused on improving care of older adults. It's obviously important to you. We included a request, one questionnaire in the registration material and had lots of responses back. And clearly people had a wide range of interests in the topic. The most enthusiastic of you said things like everything, and some said even more. But the other topics that came up regularly were care planning, how to limit the use of restraints, treatment options, prevention and management, diagnostics, medications, education for frontline staff. And actually, I think many of those topics are going to be covered or at least touched on today. But far and away, the largest number of you said something around screening or strategies for assessment or how to build those things into your workflow. And about 50% of you said that. So if that was you, you're really in luck because that's going to be the focus of the webinar today. Screening tools for the assessment of delirium, identification and assessment of delirium in the emergency department, and how you can build it into your workflow. As usual, we've got a wide range of folks on the line today. Our audience usually is clinicians at the bedside in the emergency department, doctors, nurses, and the interdisciplinary team of physiotherapists, OTs, social workers, pharmacists, etc. Also some planners and administrators. As we're getting started, could you please text into the chat selecting everyone? So text into the chat where you're calling in from, where in the world you're calling in from, and what your role is there. Next slide. The Geriatric ED Collaborative, as many of you know, is a network of community and academic emergency departments working together to define best practices. So we've got a number of activities. We educate ED clinicians about models of care to improve the care of older people in emergency departments, which is sort of today's mandate. We support EDs as they implement those changes, and we do research and evaluate the outcomes of those changed models of care. If you share that vision, your ED can join us currently for free. We are putting the link for the partnership into the chat. International members are definitely welcome. Check out our website, which is on the screen at the moment. Please join us on Twitter at the GEDC, and those things are available. The GEDC is generously supported by the John A. Hartford Foundation and the West Health Institute, and we really thank those two generous foundations for their support of us. It allows us to keep doing this work that we think is very valuable and important. Today's webinar is being recorded. A link will be available to you. The recording and the content of the chat and the slides will all be posted on the GEDC website within the next week and will be available for you to peruse at that time. And we'd also remind you that all of our previous webinars, which is now in the 2025 number, covering really most of the main topics in geriatric ED care, are also available on the GEDC website. As we go along, feel free to text into the chat box any specific questions that you have for our panelists. We really have a brain trust of Delirium on the call today, representing, coming from 3 countries on 2 continents. So it's rare that you get a chance to ask an expert like this. Before I introduce our panel, next slide, we have one question that we would like you to answer in the poll, which will appear on your screen. In your ED, what screening tool do you use for delirium? There's an opportunity to select more than one, and I'll give you about 30 seconds to answer that question. Good, thank you very much. I actually can't see what results are coming in. So Connor, can you put that on the screen? Thank you, now I can. So that's very heartening. I was very worried that the largest number of answers was going to be nothing, but it's not. In fact, it's not the lowest, it's sort of the middle number, I guess. So we've got a little bit of a cage match today between 4AT and the bCAM, and currently Jin is showing a strong advantage because it looks like 37% of participants are using some combination of the DTS and or the bCAM. 21% are using the CAM itself, and 12% use the 4AT. There's an interesting geographical bias. I think the bCAM tends to be more common in North America, with the 4AT more common through England, the UK, Australia, and Asia. So that gives us a point to get started from. I'll close that poll, and next slide, please. I would like to introduce our panelists now. First of all is my Canadian colleague, Debra Eagles, who's an emergency physician and formerly a physiotherapist at the University of Toronto, where she's an associate professor. Deb and I, nearly 10 years ago, were the 2 co-founders of the Canadian Geriatric Emergency Medicine Committee at our national organization. So we are sometimes referred to as the mother and father of Canadian geriatric EM. Atul Anand is a geriatrician at the University of Edinburgh. He's the senior, where he is also a senior clinical research fellow. He works closely there with Dr. Alistair McCulloch, who is the originator of the 4AT tool. And Jin Han is also an emergency physician and an associate professor at the Vanderbilt University and with the Tennessee Valley Geriatric Research, Education, and Clinical Center. He's the originator of the DTS and bCAM. And finally, Michelle Moccia, who is a welcome return visitor to these webinars. Many of you will know her. She is a program director and of the senior, she's a nurse practitioner and a program director of their senior ER at St. Mary Mercy Hospital in Livonia, Michigan. So thank you. I'm going to turn first to Deb, Dr. Eagles. You've written a lot about delirium. It's your kind of academic focus. You've written a lot over the years. But one of my favorite articles is the one you recently co-authored with Dr. Danya Kuja in the Journal of Geriatric Emergency Medicine. And it was about common pitfalls in the care of people with dementia. Deb, can you just tell us a little bit about that article and what are the 2 most important pitfalls that emergency doctors and nurses have?
Sure. Thanks so much. It's a real pleasure to be here today. I'm going to start by just sort of sharing with you a couple of cases that happened in our emergency department. I'm sure a lot of you will relate and have seen similar things in your own emergency departments that illustrate some of the common pitfalls that we see. So the first case is an 82-year-old female who's from a retirement residence and had multiple presentations to our emergency department over the course of about 2 weeks. And when you look back at the medical record from those visits, it's clear that the patient was confused at each presentation because you see documentation like difficult historian, not sure why she's here, not oriented to place. But only on her fourth visit was collateral history actually garnered from the retirement residence where she lives. And it in fact was quite surprising what it revealed. The patient had no known history of dementia and in fact was very high functioning at baseline. Up until about 3 weeks ago, she was driving and she used to be known for helping out all the other residents at the facility. And she only lived in the retirement residence because her husband had had increased care. So her delirium was missed with multiple ED visits. And this was likely because of her age and her place of residence. And it was presumed that her altered mental status was due to baseline dementia, when in fact it was a missed delirium. And so cognitive impairment, while common in older adults, certainly is not normal. And the pitfalls that clinicians often fall into is assuming that the cognitive impairment that the patient presents with is chronic, and they do not validate or refute this assumption with collateral history. And so one of the takeaway points that I want you to get is that if a patient presents with cognitive impairment, it is imperative that you gather that collateral history from family or caregivers to determine, is this new or is this the change from their baseline? As this is one of the key diagnostic criteria for delirium. In the ED though, sometimes that collateral history is often difficult to get. And if that is the case, you have to assume that this impairment is new, and then you evaluate further for delirium. So let me give you another case. 78-year-old male brought to the ED by his daughter with whom he lives because of cough and fever. And in his medical record, it is documented that he has dementia, but the daughter shares with the bedside nurse that the patient has a mild dementia, but for the past 12 hours has had increased confusion and somnolence. Unfortunately, this information is not shared with the ED physician who assesses the patient after the daughter has gone home. The patient is admitted to hospital with pneumonia, but there's no documentation of this acute change consistent with delirium. And the patient unfortunately falls while attempting to get out of bed and fractures his hip. The information regarding the patient's acute increased confusion was not shared with nor sought by the treating ED physician. So it was not recognized by the physician and nor the admitting team, which is often common. And the confusion was attributed to his known dementia. But dementia encompasses a broad range of cognitive function for which the diagnosis alone really gives little indication of the level of impairment. And we know that patients with dementia are at increased risk of delirium. So for these patients, it really behooves the clinician to determine the level of baseline cognitive function, evaluate for and monitor closely for any changes. For this patient, the misdiagnosis resulted in failed opportunities to mitigate the negative sequelae of delirium and may have contributed to the patient's fall and subsequent hip fracture. So in this case, the pitfall relates to the lack of communication regarding the diagnosis of delirium to all the team members. And this is particularly important during transitions of care, including transitions between shifts, between treating teams, such as the ED to inpatient team, and on transitions to and from community. And so the takeaway is that communication of the delirium diagnosis is instrumental for appropriate management of patients. And this includes both verbal and written documentation. And I would encourage you to actually use the term delirium so that there can be no confusion, no pun intended, as to the acute nature of the altered mental status and therefore its associated negative patient outcomes. Now, this communication involves explaining to family members what delirium is, how it's affecting their loved one, and how they can assist. More importantly, it involves explicit communication with all team members such that appropriate investigations and management plans can be instituted, and communication on transition back to the community if the patient is not at their baseline level. So while there are many challenges to diagnosing delirium, being aware of the common pitfalls and how to avoid them is really going to help equip clinicians with tools that they need to confidently evaluate for delirium in our older ED patients.
Thanks a lot, Deb. One of the things you mentioned there is I think a version of what is sometimes called diagnostic momentum, where a diagnosis takes on a life of its own. I think the situation here is often the absence of making the diagnosis takes on a life of its own. I worked all weekend. We're out at triage a lot because the department is so full. And I hear these conversations even between EMS technicians and the triage nurse. The triage nurse says something like, "Oh, is she confused?" And the EMS person says, "Yeah, I think so." And suddenly that becomes a truth that gets entered into the chart, confused at baseline. Whereas there's really very little basis for that. And it as you say, it behooves all of us to really be, on our toes about making claims about what we do know and what we don't know. And if we don't know something, act on it. So those are some things that all of us, and I'm not pointing fingers at anybody because that happens to all of us. So that's what happens at the level of the clinicians. What about the system in which we all work? What can we do to improve it?
So as you were saying, from a clinician perspective, I think it is really that high level of clinical suspicion for entertaining the diagnosis. But system level processes are really key, because I think the culture and around the way that we talk about delirium and approach delirium is really important for elevating the level of care that we can provide. So I'm going to speak to some broad concepts, but sort of to understand that for successful behavioral change, the implemented strategies really need to be individualized to best suit the needs of everybody's individual facility. So it's pretty widely accepted that implementing a system level screening program, including validated tools, which Dr. Han and Anand are going to be describing shortly, is really critical. But understanding your available departmental resource does matter, and screening every older adult oftentimes is not appropriate or feasible in your system, and therefore can lead to a failure of the screening program. So you need to think about targeted approaches to screening, because sometimes this is going to be more successful in your environment. And the screening program is really only one part of an integrated overall program of delirium care that your facility hopefully would have. And it begins with delirium prevention and includes screening and then subsequent delirium investigations and management pathways. It's also critical that there are identified actions that result when delirium is actually diagnosed, and that there's a clear mechanism, as I was saying, to convey that diagnosis to all healthcare providers to ensure optimal ongoing care. And the more that we can build it into the system, the more that this reinforces the importance that the diagnosis of delirium has and fosters a culture of really increased delirium awareness overall.
So it's interesting you mentioned one of the points along the pathway there is delirium prevention, which I think might take many emergency department clinicians by surprise of saying, "What? How can I prevent dementia, prevent delirium?" What would you say to those people who think that delirium is just something that is there or isn't there? How can we prevent it?
So some patients come to the emerge with delirium, but we cause a lot of delirium in the emergency department for various reasons. Some of those things that we can change, but there is evidence to support different programs of care that can help to decrease the incident delirium that we are generating in the emergency department. And I think that because the outcomes are better when we prevent delirium, I would say, than actually when the patient already has delirium. We want to stop that. As they say, we don't let the horse out of the gate. Once it's out, then we're dealing with a lot more problems. But if we can actually prevent it, we're way ahead of it.
Yeah, and I don't know, well, I do know what it's like at your place, and I suspect it's pretty similar to around the world, that there's a lot of older people waiting a long time in emergency departments. We know that every hour that goes by is an opportunity to do things better. So, make sure the person is comfortable, fed, has food, a warm blanket, a chair to sit in, chairs for their family members to be in so that there's somebody to talk to that person, to keep them oriented and keep their mind stimulated. All those things which seem like sort of trivial, that's not really my job kind of things, make a huge difference to make sure that we're preventing the development of delirium or mitigating its severity. So thanks a lot, Deb. I'd like to go on to Dr. Anand, Atul. You've been working with the father of the 4AT, Dr. Alistair McLulick, for a long time. So, this is a tool that may not be familiar to many of our audience. So can you just tell us about the 4AT and its components and how we can use it?
Yeah, thank you, Roger. It's a real pleasure to be here, and absolutely delighted to represent the 4AT, particularly with as we now see, only 12% of the audience using it. So very delighted to explain a little bit more about it. So I've been working with Alistair McCulloch for well, over 15 years now, but going back 12 years is when he really first came up with a group of people with the 4AT. I think it's maybe helpful just to explain a little bit of the context as to the challenges that we were trying to solve by bringing in the 4AT. The first was really, and we've been hearing about this in the previous discussion there, was a lack of ownership around delirium and a lack of feeling that people could make that diagnosis outside of a specialist medical type domain. This is going back 10 years. It was very much in the realm of psychiatrists or geriatricians in our unit. And it really was not something that a nurse or a therapist would feel comfortable saying. The second was that even if someone did want to diagnose delirium, we felt that the screening tools were really too long-winded to be able to work in an emergency room department, you know, where you've got that high throughput and that need to test a lot of people very quickly. And the third real challenge was around so-called untestable patients, people who have a hyperactive state, who are quiet, sleepy, who have delirium, but traditionally have perhaps been deemed to be untestable by other techniques. So just to go through the 4AT, for those who are not familiar, I think in the chat there's a link up to the website that Alice has put together, which has got a lot of material, and you can see the scale for yourself. But it is the 4 A's test, so there are 4 components, all beginning with the letter A to make it easy to remember. So the first is around alertness. So it's looking for that state of arousal, whether that be drowsy or hypervigilant and hyperactive. And there the scoring is either 0 or 4. The second group is around a test of the abbreviated mental test. So we use a 4-point abbreviated mental test, asking the patient to recall their date of birth, their age, where they are, and what year it is. And the scoring here is between 0, 1, or 2, depending upon how many errors that the person makes. The third area is attention. And attention is really, for me, one of the cardinal features of distinguishing delirium from dementia. We were just hearing about that. So we use the months of the year backward test, so asking the patient to start at December and go through the months of the year backwards through the calendar. And again, the scoring here is 0, 1, or 2, depending upon how many errors someone makes. And if they can make it all the way to June, then they get 0 points. And then the final area is around acute change. And we were just hearing about the importance of a collateral history or an informant history to understand whether this is a new change in a person or whether there's a degree of chronic cognitive impairment. And so here the scoring is either 0 or 4, where 4 suggests an acute change. So adding all that together, the 4AT gives you a score between 0 and 12. We suggest that a score of 4 or above is suggestive of delirium. One of the potential added benefits of the 4AT is that we also can make a comment on possible cognitive impairment, so suggestion of chronic cognitive impairment at a screening level for patients who score 1, 2, or 3, and 0 points would obviously be a normal score. So in terms of comparisons with other tests, it's pretty quick. It takes 2 minutes or so. That potentially doesn't include a collateral history, but if you know something about the baseline of your patient, you can have this all done and dusted within about 2 minutes in our testing. And it's something that we've found is actually very easy to embed within our electronic health record system. So we've recently published some work showing that in the first 4 years of the test being embedded in our electronic health record system, we had a 77% completion rate for medical patients within 24 hours of admission. Now that admittedly takes you slightly beyond the ER, and it's still a challenge for us to get our emergency department colleagues to be putting the 4ATs on the electronic health record system. But you know, this was across 48,000 patients in 3 hospitals, and 77% of them having a 4AT, we thought was a pretty sound result. And then just finally, I suppose it's worth mentioning a little bit of the evidence here, because a lot of the tools that are out there have really good evidence, and I think the 4AT is up there with this. I think we now have more validation studies for diagnostic accuracy of delirium than any other tool, and it's been brilliant that so many colleagues around the world have taken that on. So we've put together a meta-analysis that was published last year, looking across 17 different studies where the 4AT was compared against a diagnostic standard for delirium. And the sensitivity and specificity came out at 88%, both sensitivity and specificity for delirium against a gold standard measure. So we're pretty happy that we have a test that works in practice, that can be embedded. It's pretty quick, and it has pretty good diagnostic accuracy for clinical delirium. So hopefully that's a good introduction. I'm really happy to talk further about it as the discussion unfolds.
Yeah, thanks a lot, Atul. So just a reminder to the audience that there's obviously a lot more detail available about this test. I would encourage you to go to the website that Dr. McClulick and Atul have put together, which is in the chat. It's a very tidy little website that really gives you everything that you need to know. Atul, can you tell us anything about how it's been implemented either at your site in Edinburgh or across the National Health Service, which covers all of the United Kingdom? Is it in place in most departments?
Yeah, so it has been adopted by NICE, who are our kind of Institute of Clinical Excellence. So it is the recommended screening tool in the UK for delirium. Every implementation so depends upon clinical systems. So when we first went live back in 2010, 2011, we were using bits of paper, and I'm sure there are places around the UK that are still using bits of paper. I think the real strength of getting it implemented in the EMR is really around actually showing a clear audit and sort of validation that you are doing what you're saying you're doing. So it's so easy now for me to be able to extract data around the sort of tens of thousands of 4AT assessments that are done every year across our acute hospitals in a way that we could never do before. So, you know, this is not unique to delirium. This is the future of electronic health records. But really, it's really pleasing to be able to see that actually it's being done, and also the scores really relate to outcomes. So what we showed recently was that, you know, if you do have delirium, your risk of dying in hospital is 5-fold greater than if you didn't. And that's the kind of routine data research that I think is really powerful for communicating the importance of screening and early treatment of patients with delirium.
Thanks, Atul. And your comments relate to a little side chat that's going on in the chat at the moment, which is around, you know, the use of the word delirium, and is it a diagnosis? No, it's not. It's a description of a syndrome. And so the importance of, you know, using the word, as Deb said, but also, you know, there's a big difference between pneumonia, period, and pneumonia with delirium. And the outcomes, as you say, the person who just has delirium or just has pneumonia is unlikely to be dead in a month. The person with pneumonia and delirium is much more likely to be dead in a month. And so it's really essential that we communicate and pass that information forward. And so if you need to use another diagnostic code for billing purposes, that's fine, but just make sure that you're identifying the delirium and passing that on to the treating team. So thanks a lot. We'll come back to you again, Atul. Jin, over to you. You've heard about your competitor, and you have to overcome the cumulative weight of the National Health Service and the National Institute of Clinical Excellence to convince us that the delirium triage screen plus the bCAM is the way to go. So tell us about your tool, please.
Yes. So thank you for inviting me. It's an honor to be here and to talk to you all about the DTS and the bCAM. First of all, I don't see the 4AT as a competitor. It's just another tool that's available. And I think Eula said it best. It really depends upon your health system and, you know, what the needs are. And I think, you know, I'm not like, use what's best for you, and something's better than nothing. That's the motto that I always go by. I think as long, and ultimately our patients are going to be the beneficiaries regardless of which tool you use. But anyways, the reason why I developed the bCAM was out of need. When I first started as a researcher, I saw two needs. One, we miss delirium a lot in the emergency department as clinicians, both nurses and physicians. And I was also looking for a simple tool for my research staff to use, my research assistants, who had very limited clinical experience. And at the time, the CAM was the most widely used delirium assessment, but unfortunately it took 5 to 10 minutes to perform. And to determine the presence or absence of features was based upon subjective impression. So it was one of those, yeah, is it there or not? And there's really no objective testing performed. So I didn't think the CAM would be very feasible to perform the ED, not only for my clinicians, but for also my research assistants, So I was looking around for alternatives and found the CAM ICU, or the confusion assessment method for the intensive care unit. And that was actually developed fortuitously by my mentor, who introduced the tool to me. And the CAM ICU uses the same short form CAM algorithm, but it was briefer to administer, taking 1 to 2 minutes. And more importantly, it used objective testing to assess inattention, disorganized thinking. And this has made it simpler to use, more reliable to use, and less operative dependent in those who have limited clinical training. So we started using the CAM ICU in my early research studies, but the more I used it, the more I realized that it was missing delirious patients. So we looked at the CAM ICU, where was it falling short? And it was falling short in the inattention test, as well as the disorganized thinking. And what we did was we modified this accordingly and improved the and thus the bCAM was born, and improved its sensitivity without sacrificing its specificity on subsequent validance studies. But after presenting this to my colleagues, and not only across the country, I got a lot of comments that even the 1 to 2 minute delirium assessment was a long time. And I think that's an eternity for an emergency physician. And can we make it shorter? And I think that's why the DTS was born. And I guess the DTS, what we did was we designed it to be an ultra brief delirium assessment that takes less than 30 seconds to perform, and has 2 components. It assesses inattention as well as an assessment for level of consciousness. And with these 2 components, we found that the DTS is highly sensitive, over 98%. So a negative test effectively rules out delirium. But the problem with the DTS, it's moderately specific, so about 55%. So if positive, it requires a confirmatory, more specific delirium assessment, such as the bCAM or the 4AT, to be performed. But in the end, the DTS increases screening efficiency by reducing the number of formal delirium assessments needed by 50%. And the way I like to think about this 2-step approach is DTS to bCAM. It's analogous to the D-dimer approach for pulmonary embolism. So a D-dimer is highly sensitive, and negative test rules out pulmonary embolism. However, a positive D-dimer is moderately specific. So if it's a positive D-dimer, leads to a more confirmatory test, which is a CTA of the chest. And that's pretty much the DTS bCAM model. And I think one thing I want to mention, if I could, Don, I think there's been a lot of confusion about the DTS and the bCAM. And I actually created these tools to be standalone instruments, but for whatever reason, I guess an error of our own, we kind of packaged them together in a manuscript. But the reality is these tools can be used with some flexibility. So you can use the bCAM by itself. Alternatively, you can use the DTS as the initial delirium screen, and then another confirmatory delirium assessment, such as the CAM ICU, CAM, or the 4AT. So I just wanted to point out that there's flexibility in the way you approach delirium monitoring, and really depends on the ED itself and the hospital system itself.
Yeah, I think that's a really important point to make, Jin, is that I mean, I think of them as like a pair, and it's important to remind people that it's not the case. Could you just give us a brief description of the DTS and the 2 components of it, and how it can be used truly at triage?
So we took the 4 components of the short form CAM, right? So ultramental status, or fluctuating course. Feature 1, feature 2 is inattention. Feature 3 is disorganized thinking, and feature 4 is all level of consciousness. So we just took inattention, which we considered one of the critical components of delirium, and we asked the patient to recite the months backwards from actually to name the months. I'm getting my tools confused. To spell the word lunch backwards, right? I'm hungry right now. I'm a little delirious, but spelling the word lunch backwards, because we thought that this was a very difficult task for a cognitively impaired, let alone a cognitively intact person to do, because we wanted to emphasize sensitivity. And the other component is level of consciousness, where we use the Richmond Agitation Sedation Scale, the RASS. So if the patient has an abnormal level of consciousness or are unable to spell the word lunch backwards, then that's a positive DTS. So if they can spell the word lunch backwards and they have a normal level of consciousness, then pretty much delirium is ruled out. So that's that, and then you can move on with your life with the patient.
Yeah, that's cool. I think one really cool thing about the DTS is that both components of it are things that everybody working in an emergency department are familiar with, including the Richmond Agitation Sedation Scale, which maybe not everybody knows the term, but in fact, it's a part of like conscious sedation, a component of intoxication processes in the emergency department. And every emergency department clinician is able to identify if a patient is awake and alert. And that's a 0, and that's the only score that counts for the DTS. So it's very user-friendly within the emergency department. Now, if you're following the chat, Chris Carpenter is looking forward to, Chris Carpenter being one of the other world authorities on cognitive impairment in the emergency department, he's looking forward to the Saturday night wrestling match between the two of you. But in the spirit of geriatric care, we tend to be gentler, kinder folks. And so I'd like to ask both of you what you think is the principal advantage of the other's tool. So I'll start with you, Atul. If you were advising somebody to select, what do you really like about the DTS and or bCAM?
Yeah, I mean, first of all, just to echo Jin's comments, I think using any test is better than using no test. So I'm completely on board with that. I think, whatever works for you. But I mean, I think I've got a lot of time for the DTS and bCAM. I think they're really smart. They're incredibly brief. I talked about 2 minutes for the 480. Here we are even shorter with the DTS. And I think it has picked out those 2 key components that I see as being critical for the delirious patients that I see, the altered alertness, arousal, and the inattention, and I think that's smart. So I, in terms of a screening test, I feel like we should always be prioritizing sensitivity over specificity. I don't mind having a few false positives if it means we don't miss delirium. So I think it's a really smart and repeatable tool that can be used really quickly in the emergency department. And it's probably one of the things we haven't done with the 480 is get it into the ER, because it just takes a little bit too long.
Mm-hmm. Over to you, Jin.
I want to point, one of the strengths about the 4AT is, in addition to being well studied, right? I think it's overtaken the CAM as far as the number of patients enrolled in studies, and Alistair and Atul have done a great job in terms of implementing it and spreading the word of the 4AT. But I think the other thing about the 4AT is that, there's multiple ways to get to a positive. So the bCAM or the CAM algorithm is very regimented. You have to have features 1 and 2 and either 3 or 4. But for the 4AT, you can kind of get to a positive 4AT in multiple routes. So for example, if you have altered mental status or fluctuating course, that's 4 points and you're considered possibly delirious and you're done, right? So the other ways, if they markedly have abnormal level of consciousness, I think that's 2 points. Plus you have make some errors on the abbreviated mental test 4, then that's another way to get to a positive test and you can stop. So conversely, the bCAM, if they're negative, you can do early stoppage rules as well. So I think the bCAM is faster for ruling out versus the 4AT's faster test for ruling in. But yeah, the bCAM is definitely less sensitive than the 4AT, but arguably maybe a little bit more specific. But I think it all depends on what you're going to do with a positive test. If the goal is to minimize the false negatives, and I think the 4AT is a definite test. But if you're going to attach a very expensive and resource-intensive intervention, then you may consider the bCAM a better test because it's going to be more specific.
Good, thanks a lot, Jin. That theme of doing anything is better than doing nothing was a common, and that's a real emergency medicine dictum as well. Sitting around doing nothing is almost never the right thing to do. You've met the topic of the CAM has come up a couple of times, and we haven't talked much about it. I can tell you that about 10 or 12 years ago, at our place at Mount Sinai, we did implement it, and it has never really been a very big success. So I'm very interested to hear from Michelle now, who runs a very high-performance, high-functioning geriatric emergency department, about her experience of all of these things and actually implementing them at the bedside. So Michelle, tell us about what you do and how you've integrated delirium care into your emergency department.
Great. Thank you, Don. Thank you for inviting me to speak about this. One of the things I can tell your audience that's very important is if you don't know where you're going, how do you know when you get to your destination? And what I'm saying about that is that I think it's very good to do a survey, to actually survey your staff to see where they are. How much do they know about detection, management, and prevention of delirium, and have them rate their knowledge. And just to let you know that when we went ahead and did that, we found out that 50% of our population, and we surveyed our ED nurses, our physicians, our residents, our NPs, our PAs, our social workers, and our techs, to tell us to have them rate their knowledge on delirium detection, management, and prevention. And what we found out is about 80% of them said they had an intermediate, basic to intermediate knowledge. So it really told us we have some work to do. What we did find out, though, when we asked them, does the ED have a protocol in place to identify delirium? 94% said yes, and we're like, yay, at least they know we're using a tool. And actually, the tool we use is a confusion assessment method. And the reason why we use that tool is because we had Cerner as our EMR, and then we went to Epic. That was what was available to us. So we continued to use that tool. And then we asked people how often is the protocol followed, at least 50% of the time, and 91% of the people said yes. So that was really good. And then we asked them, in your opinion, does ED consider delirium a top priority? And about 79% said that they did. So we felt really good on that. And then we asked them, what are the key issues or knowledge gaps in diagnosing, preventing, or managing delirium in the ED? Because this is very important, because this is going to be the fundamental, right, of the whole education. And 54% said they had a challenge of identifying delirium in those with dementia. They really were like, how do we do that if they come in with dementia? Are they delirious or they're not delirious? So we really had to look at that, and we actually created a table of characteristics of delirium and dementia to help differentiate that. And we really told them that the patients with dementia, they're the highest risk for delirium. So they come in an altered state. You can get that collateral history. Say to yourself, that patient has delirium unless you can rule it out. Say to yourself right away, that patient has delirium, because we know that often patients that have dementia, they can't communicate to us, right? So if something goes wrong, they start acting different, right? Or they get really sleepy, hypervigilant. Something's not right. And I always tell people, every behavior has a meaning. So we got to figure it out. What is going on with this individual? Why are they climbing over the side rails, right? Find out what it is. Give them a hand gesture. Maybe they want to go for a walk. Maybe they have pain. Something's going on. We have to figure it out. And then we asked them, they said 42% lack available collateral information. And we heard that today from our first speaker, Dr. Eagles. She said it is so important. And even if you don't have it, just say that it's altered. We got to get that collateral information. So I think we do a really good job here. If we don't know, we go and call and find out. Find somebody that knows them so you can find out with that collateral information. And we've really worked with our pre-hospital providers too. So when they come in and they say altered, we go, what does that mean, right? Tell us. So they're getting better and better saying, well, they were alert and oriented ×4. That's what they told me. But today they're only alert and oriented ×2. So that's really good. So we've really worked with EMS. And then we have 34 facilities that surround us. No kidding. Assisted living, independent, senior high-rise, and skilled. So we've worked with them too to make sure if they're sending us a patient in for the altered mental status to give us that collateral. And then we found out too that 35% lack knowledge of pharmacological management strategies. They didn't know exactly what to do. And remember, this is everybody answering these questions. We had about a 47-48% rate of return of the surveys, which is really good. So what we did is we developed a delirium management protocol. We created Beers medications of the month. We did that. We did Pyxis alerts, like a Pyxis alert that would alert if somebody went to go get out lorazepam, it would say, is your patient positive for delirium? And if the nurse said yes, it'd say, caution, benzodiazepines are contraindicated in this patient, to return and go back, talk to the physician. So, and then we worked with our coders for billable codes. You saw that in the chat too. We looked at that, and we really found out that if ER does own this, if we call it out, if we say it's delirium due to a known physiological condition or delirium due to sepsis, delirium due to UTI, if we called it out, it was more likely it would carry on We actually saw that in inpatient. And then also we asked the staff too, is that what tools or resources are you going to need? And they really felt that they really needed to understand what are some non-pharmacological approaches they could use. So we talked about that, making sure, and I'm preaching to the choir here, a lot of people on this call, make sure they have their hearing aids, right? If they have that, make sure they have their visual devices. We have hearing amplifiers, maybe dimming, the room, making sure they're hydrated, playing some music. We actually developed a therapeutic activity cart too. So we have a lot of different things in there for patients. But again, this therapeutic cart, I do want to let you know it's for anybody. It's not just for patients with delirium. It could be somebody that has dementia. It could be a behavioral patient. It could be a child. It could be just somebody that's bored. Go get them something out of that cart so they can do something while they're waiting for imaging and their results. And we all know the key to education is what? Food, right? How many of you have this in your ear? You hear nutrition in service in the break room. Everybody knows there's food in the break room when you hear that. So what we developed snack facts. So what we did is we got all these different snacks, and I went into the doctor's lounge too, and I took all their snacks and I started putting labels all over them, like contributors of delirium, consequences of delirium. So giving them snack facts about delirium. And the other thing we really wanted to impress, and I've heard it from all our speakers today, that you really have to create an awareness. This is very serious condition, right? There's terrible consequences. This is a brain attack. This is acute brain failure. And these patients are going to have long-term cognitive impairment. They have risk of institutionalism. We heard from our speakers, high mortality rate. And this is so sad that these patients will go back and they might not be able to do their ADLs like they used to do before. And God forbid somebody ends up in an institution that used to reside at home. So we've done a lot of things around education, like I talked to you about. We developed process flows. We actually also developed badge cards, and on the back of them spells out the word delirium and all the contributing factors. We also took that and made bucket cards too, so people can put in their pocket. We also hanging off all our walls. It says how to assess for delirium, the CAM. And if you can see it, it's blue on one side because the rhyme is if feature 1 and 2 are blue or true, and a positive score in 3 and or 4 equals what? Delirium. So maybe we made it fun and catchy like that so people could really catch on. And then we did a delirium t-shirt contest. Yeah. Did that, and we have a t-shirt on that. And I do want to let everybody know too that so many of you put so many queries in there, what you wanted to know. If we didn't cover it today, there is actually a great toolkit out there that's called Delirium in the Older Emergency Department Patient. It was actually created from West Health Institute and Dr. Sharon Onaway and Dr. Don Malati, who's on the call right now. He was one of the ones that put it together. And I know Dr. Ula has been also instrumental. And then we were one of the EDs that actually took that toolkit, and it's a change kit too. We actually piloted it. So it actually helped really improve our momentum. And the other thing I can tell the audience too is that your patients and their families, especially their visitor that's in the room, is really hungry to understand delirium. So have a delirium brochure that's ready and available to help explain it to them. And we actually created a delirium brochure. We worked with our patient family advisory committee because we wanted to hear it from them. Does this make sense? So they actually helped us develop it, and it's actually in that toolkit too. A lot of the things I'm talking about right now are in that toolkit. And I have to tell you that that is the most frequent brochures of all the brochures we have in each of our ED rooms. It is the most frequent one that I have to replace. So it isn't just because we're identifying delirium better than we've ever did before, but families are taking it. So which is really good.
Thanks, Michelle. As always, extremely enthusiastic and practical. It really takes all the the theoretical and theoretical and shows us what you can do at the bedside in the emergency department. You're clearly a very experienced emerge person because you know about food. Pizza always wins the day.
Yes.
But so just with regard to education and implementation, could you just tell us a little bit more about the DEL? Because you were a trial site for that, and because I don't want people to believe that it is just something that needs a lot of money to implement it, or needs to be at a big fancy university site, because you guys are more or less a community site. Tell us a little bit more about some of the things in the Delirium toolkit that you used.
Wow, there is so many things. It's like 100+ pages. So there's actually slide decks in there to help you do education, so you don't have to invent the wheel. I talked about the brochures. It actually has pharmacological management strategies to do, non-pharmacological management strategies to do. There's actually a tool in there called to see if your organization is ready to make a change. That's in there. There's PDSA cycles that are in there. There's the consequences of delirium. There's transitions of care too, which we heard this morning. The earlier speaker was talking, Dr. Eagles was talking about. There's about transitions of care in there. It's filled with a plethora. Let me just say this, you don't have to invent anything. That toolkit has so much information in there to help you design a successful identification of delirium management and prevention in your own institution. And there's just so much in there. There's 3 other EDs that actually help do that. I'm just going to shout out Maine Medical Center, Mount Sinai, University of North Carolina, Hillsborough Campus 2. They did this. There was 4 of us that worked together. We tested this kit, and then the momentum from all of us, we just created other types of things so that we can really raise awareness on this acute brain attack that is really devastating for anybody who gets it. So I appreciate you asking that question.
Good. Thanks a lot, Michelle. So Eula, you've been keeping your eye on the chat. There's a lot of stuff going in there, not just comments about young and strong or old and cagey. But Eula, is there anything else, any questions or comments that you want to direct to any of our experts?
Yes, thank you. Actually, I think a question that Luna Ragsdale just brought up would be a great one for perhaps all of the expert panelists to comment on. Who performs the delirium triage screen in your emergency department, and does that matter?
Michelle, I'll start with you, since you're the kind of main clinician here who designed the system, but I guess you're not really using DTS bCAM. But you do use the CAM, and who does it, and how do you designate that person, and what happens? So start with that. Who does it, and how do you designate that person?
So our RNs do the CAM. And but we do
primary care RN, not triage.
EDRN does the CAM, and then our ED physicians know how to do it too. It does happen sometimes that our ED nurse may score it negative, and the doctor feels it's positive, and so they talk together, all right, regarding it, and vice versa, right? Mm-hmm. So if the nurse says the patient scored positive for delirium, but the physician doesn't feel that it is positive for delirium, there's a dialogue that goes on regarding that.
So Atul, I'm going to ask you, you're a geriatrician who actually knows where the emergency department is, which is good. So in your emergency department, I know that this is the 4AT is the target is to be done within the first 24 hours. But in your emergency department, whose job is it to do the 4AT?
I think predominantly done by nursing staff, and I suppose the other advantage is that nursing staff put it in the right bit of the EMR, whereas medical staff, I'm afraid, tend to just write it in the notes, which is less useful for us when we're trying to evaluate impact, because if it's just written in a whole load of free text, it can be difficult to work out if it's been done or not. I think it's really nice to give feedback to people, but it's predominantly a nursing-led task for us.
And I assume the UK uses the same system of triage initially and then primary nurse and physician workup. So is this a triage activity or a primary nurse assessment?
I think it's more likely to be primary nurse after the triage.
And Jin, the DTS is the delirium triage screen. Is that your intention that it actually be done at triage, or what do you say about that?
It was purposely, yeah, it was meant to be done in triage, but it can be done in the bedside. So I know like Pittsburgh, they use the DTS by the bedside nurses, and then the physicians do the bCAM. But most people have implemented it, and some people do the same person does both, right? And so I think there's many iterations, but originally the DTS was designed to be done at triage.
So I have a question coming out of that. Oh yeah, that's a good one. So Michelle, can you inform us about the TADA approach, which some people will be familiar with?
So that's in the toolkit too, because someone did ask, is there any information about agitation? That's also in the toolkit, but some of you may have heard the TADA approach means that you need to, tolerate some of the behaviors that's going to go on. You're going to anticipate what they might do too, like pulling out IVs, removing the tethers. And then also one of the big key things is don't agitate the person. Whatever you do, try to stay in their world, try to redirect them, try never to say no. How many times have I told you to get out of that bed? No, you got to use your call valve. You have to use a different approach. So that's what's called the TADA approach. Pretty easy, right? Tolerate, anticipate, and don't agitate.
I'm very pleased that the chat box hasn't been filled with questions about what the right dose of haloperidol is. I think we've got a more sophisticated audience on our call here today, and knowing that identifying and managing and preventing delirium is important. Eula, you have another comment?
Yeah, so we have actually a comment sort of question from Maura Kennedy. She's in the audience, so is not able to verbalize this, but she's another international expert and has done extensive research on delirium. And she had the question actually to Dr. Anand about basically assessing for collateral history. Could you comment a little bit about her question?
Yeah, so I think just raising the challenge of getting a collateral history, I think it's a very fair point. So I think when we looked at this a long time ago, about 1 in 4 patients just couldn't get it. There was no possible collateral history available within that kind of first period of admission. And so I think the points that were made by Dr. Eagles at the beginning, assuming that someone has a new confusion is the safest policy. I suppose if your delirium is going to trigger, if making that positive screen is going to trigger some good action, some good geriatric care, then I think there's no harm in assuming that. But we also find that, actually it's a real education moment for people to see that they can't complete the 4AT without trying to get a collateral history. And that's a prompt for making that, picking up the phone, trying to find out what's going on, where otherwise maybe it might be easier just to sort of let that slide and just leave it for someone else down the line to do. So I quite like the prompt, even if it's difficult.
Super point. I mean, and avoiding the ageist attitude that this person is old, therefore they probably have confusion at baseline, and adopting the healthier attitude of this person is a person and probably is cognitively intact at baseline. So sadly, we are coming to an end. Eula, any comments about our audience that you would like to make?
Yeah, so I just want to comment. I think this is one of our highest attended webinars. We had over 96 participants, attendees, not including the panelists, and again, from all around the country and all around the world. So not only down under in Australia, but also down under in Brazil. We had Toronto, we had individuals from all different health systems around the country. So you had VA, you had Kaiser, and affiliates of several hospitals. I'm very excited several of my own affiliates at Yale attended. And then people from all different backgrounds. So nursing, physicians, social work, PT. So geriatrics is a team sport, and this is a team sport across the world.
Thanks a lot. So our 4 participants did put in their main messages, which will be available if you want to come to the website and download the presentation. Next slide. They're all valuable. Finally, I would like to point you towards a book, bearing in mind that this is a conflict of interest for me, since it's a book that John Schumacher and I wrote, which is available. We are offering, well, Cambridge University Press is offering a 20% discount using that discount code. And if you go to that website, next slide. Next slide. Our next webinar will be on June 6th. And you know, a lot of what came up today was educating people about education and strategies for implementation. So there's going to be a whole website, a whole webinar focused on how do you create an educated workforce. We've got a lot of valuable people, podcasters, webinar managers, website developers who will be on that. So please, and I should say, we are, if you have a project at your site around education that has been successful, please let me know about it. We would like to spotlight a couple of successful projects around the world. So if you've done something that works well at your place, let us know. Next slide. Please stay in touch with us. And final slide, we would like to send one final thank you to our supporters. And I would really, I think all of us, I'm speaking on behalf of all the participants, we'd really like to thank the 4 principal presenters here today. It was just awesome that you were able to give us all this time. And you know, you guys are the experts in the world and you were here with us. So we really, really appreciate it. Thanks a lot. And see you all on June 6th. Bye, everybody.